Welcome to Melanoma Insights for Professionals, brought to you by Melanoma Institute Australia. I'm Professor Georgina Long, medical oncologist and medical director at Melanoma Institute Australia. Welcome back to our special Vodcast series, Redefining Immunotherapy, Lessons from Melanoma. This is Episode 3, where we'll focus on immunotherapy toxicity, how to prevent, recognize early and manage immune-related adverse events to optimize patient outcomes. If you haven't listened already, I'd encourage you to go back and listen to our earlier episodes where we discuss how cancer hijacks and hides from the immune system, how immunotherapy works, and the evolving approaches to making smarter treatment decisions in clinical practice. Joining me in the studio today are my medical oncology colleagues from Melanoma Institute Australia, Professor Alex Menzies and Associate Professor Matteo Carlino. We also have Associate Professor Anesh De Silva dialing in from Portugal. So we're now gathered to talk about immunotherapy toxicity. Don't fall through the floor, everybody. It can be tiring. It really can. But prevention, early recognition, and the management of toxicity to actually optimize outcome. Now, I say that managing toxicity to optimize outcome, yes, quality of life, but also survival, we think. So let's open it up. Who wants to start on this topic? Very important topic and something that scares people from going for our doublet immunotherapy, which may cure, well, it does cure more patients. Alex.
So where do we start? Look, toxicity is really important in any setting, whether it be neoadjuvant, adjuvant, metastatic. It is a key thing that we want to minimise, and as Georgina said, we want to prevent it where possible. Can we prevent toxicity?
Let's talk about that. Let's start with that. That's one of the first things, the nuances of managing. And between us, we'd have 50 years of experience of this, at least we would. Yeah?
I'm 25.
15. Oh, sorry, you're too young. I don't know that you should be here, Matt.
So I guess prevention of toxicity.
Yeah.
I'm going to flip that because I don't think we can prevent it in the current climate, but I think it's more about predicting who's at risk of it and selecting treatment to minimise that. So
can I budge in there? I do think there's a way we can prevent it, but I'll talk about that after you've talked about what you're going to talk about.
So when we give, obviously the single agent versus combinations, the risk of toxicity is different. When we give immunotherapy on its own, which is what we do in melanoma, it's actually easier. When you give it in combination with chemo that can have additional mimicking different toxicities, it can be hard. You get neuropathy when you're on chemo and immuno, or you get a lung infiltrate on a taxane and a PD-1. It can be tricky. But I think so the drugs you pick can determine the risk of toxicity, but the patient as well. And so the classic thing that we deal with all the time in melanoma is underlying autoimmune disease. And we know people that have underlying autoimmune disease have a higher risk of flaring of their underlying toxicity. They probably have about a similar rate of a de novo new toxicity, but that underlying flare is a challenge.
And you published that. I think that was the first paper to publish that in the whole of the world in terms of immunotherapy in Annals of Oncology. What year was that, Alex? I can't remember now. It's 20-something. Long time ago.
10
but
years
Alex,
ago.
Yeah, Alex, you were first author on that, demonstrating and proving that. But yeah, keep going. So autoimmunity is something we flag. In fact, when a patient walks in, we have a box we tick, whether they have their own autoimmune disease or whether they have a family history of autoimmune disease. But
So I think that's a risk factor. Beyond that, it often can be difficult to try and predict who is at risk of getting a toxicity. These toxicities can occur in any organ at any time, in young people, older people, good performance, poor performance status, do not seem to align with the underlying cancer, which is interesting. In melanoma, we see a whole lot of people getting vitiligo when they get immunotherapy as a toxicity. but you don't get people with kidney cancers getting nephritis or
Are
lung
any-
cancer getting pneumonitis more often.
And are any toxicities associated with good outcome?
So in melanoma, we believe vitiligo is. The problem is by the time they develop it, you already know they've responded to treatment. And possibly thyrotoxicosis may be associated with response to treatment in melanoma. There have been studies in other cancers looking at other things, but they're probably the more common ones that I don't mind seeing, shall we say.
So Matt, I want to hear how you approach, let's say we've got a patient, let's go to our most toxic regimen, which is nivolumab combined with ipilimumab, PD-1 CTLA-4, because I want to talk about this, so I'm going to make you talk about it so I can talk about it too. But a patient walks in, you've never met them before, they've got liver mets and bone mets, lung and maybe subcut. They're 42 and they're V600E, so you're going to reach for the combo.
Easy choice.
Easy or clinical trial, but you're going to go that way. Let's go Ipi-Nivo this time. How do you talk to the patient about what to expect, and then how do you actually manage it? What do you do?
Yeah. So I think the first thing to say is that, there's a lot of room for improvement in this space. We've all had patients where we think we've sort of really drummed in the education about tox, and yet we'll see them in an emergency department, and when you question them in an emergency department, they'll say, I've had diarrhea for 5 days, and go, when I said call, this was one of the things to call about. So I think a couple of things that's important. It's education, and you've really got to target your education to the patient. I think there are some patients who have different health literacies. In some patients, it's the partner or the child who's the main person that's going to be the, if you like, gatekeeper. They need to have access to you or your team. So, for services like mine, who are fortunate enough to have an MIA funded CNC, that contact is primarily that CNC.
So a clinical nurse consultant who's at the frontier, basically.
It'll be different for everyone. The other thing that I think that I'm really now putting into my education is this idea that tox and even stopping for tox is not bad. There is this phobia that we will stop their treatment, and if we stop their treatment, they die. And even if it's not stated, it hangs underneath them. So they put up with bad joints, or they don't call you with the diarrhea, or they don't tell their wife they've got the diarrhea. And I think I now explicitly say that, and I often say, I have patients who got one dose of this stuff 10 plus years ago and are cured, just to really get it out there.
So I think this is a really important point, and I'd love to weigh in here if I may.
You may.
Because, thank you. Because we come from a tradition of chemotherapy. We come from a tradition of you've got to get the cell cycle. It's either got to be every 2 weeks, it's got to be every 3 weeks, depending on the chemotherapy and its half-life and what it's doing. And we treat to tox, and we try to support the patient through the tox with your GM-CSF or your anti-nausea prevention. This is different. This is not about treating to maximum tox. This is actually about stopping at any sign of tox, because it's the immune system. It is not directly killing the cancer cells. So I'm with you. The way I do it now, because I've refined it now over between us 50 years, I always write things out because every patient's different, and I have 3 things I say. I say, what do you have? What's this mean to the risk of your life? And then what are we going to do about it? And then go through things. But for Ipi-Nivo specifically, I write a timeline. I go 0 weeks, and then I go 3, 6, 9. And I say, this is today. I'm seeing you today. You'll get your injection maybe in a week or so, and I put a big IV. But we're doing bloods today. I'm going to see you in 3 weeks, but big question mark. Most people don't get this second dose. I might delay it for 2 weeks, or I might not give you any more, and I might do an early scan. And that's because, and I reinforce it, once the light switch is on, your immune system, it's on. You don't see me standing at the light switch, keeping it on. So I use a lot of analogies and really entrench this idea that you're probably not going to get your second dose, and that's okay. So then when they come in, and I say, we're not going ahead, they go, oh, great. Great. I'm not getting my second dose. My immune system's activated. I've got a bit of a CRP. They might even just a CK, a grade 1 hepatitis. I will not go with the second dose because we now know 70% of grade 1, 2s, if you give them a second dose, will get a grade 3. So that's how I do it now.
Yeah, and I think that communication can't be understated because everyone has patients that didn't we talk about this every visit, and yet there was 4 days of diarrhea. The other challenge for patients conceptually, I think, and to be honest, how health systems are set up, is typically chemotox, at least the symptomatic tox, is after the dose. So, right, you get Folfox today, the nausea is early or late, but late means day 4 or 5, right? The colitis is not day 4 or 5, it's day whatever. And I think, so the service, the whole way people's brains think is, and how many patients ask you, a slightly older patient, the daughter says, if they got treatment on Monday, should I spend Monday night at their place?
Yeah.
Monday night's not the important night.
No, it's actually for the first dose, you see it with the T cells, it's about day 9 to 14, where you might start to see the first CRP rise. And then when you give your second dose, it's basically any time after the second dose. But it's different.
Yeah, with chemo, you say, look, actually, it may not be a bad idea to stay with mum or dad.
Yeah.
For the first week or whatever.
Alex.
So I think, look, as you both said, it's all about education and immunotherapy education, not just general cancer education.
Great.
For the early years, we had people going to group chemo education to hear about their immunotherapy treatment. One-on-one education, ideally the nurse whom they will call if they have the toxicity is ideal, and setting up those the principles about one dose at a time and see how you go. We don't want to dose to toxicity, we want to dose to effect.
Yes.
And I think that
early scans
that's
if needed.
really, really important. And I think...
How do you read the immune system? Let's talk about that. So we're talking about how we dose not to toxicity. So they come in at week 3. Let's go along the timeline. Come in at week 3. You've got the Epi-Nevo book, but you may not give it. What are you reading? What are you finding out from the patient and their bloods to make that decision?
So, like always, I'm assessing response. Sometimes you can actually detect response already. You can see their lymph node shrinking, their performance status has improved, their pain is reducing, they're clearly getting better, ignoring all the rest of the stuff, so that their efficacy is obvious. We can sometimes see that. Or we're looking for any signs of toxicity. Now, just because you've got a little bit of toxicity doesn't mean you can't go ahead, but you've got to think about that.
Think about people out there who may not have treated as many patients with pure immunotherapy. Give us some
minor thyroid function changes. So they get a mild thyroiditis.
Would you stop for that though?
I would not stop for that.
Why? Because it's irreversible once it's set in, and it's not going to change how it is. Yeah, I wouldn't stop for that.
I wouldn't stop for that.
Grade 1 hepatitis, so it's gone from normal 35 to about 55.
If it was Epi-Nevo, it's a different discussion than if it was PD-1
We're talking
alone.
a young guy with Epi-Nevo
If
here
it's
today.
Epi-Nevo, I might delay a week and repeat the LFTs and see what happens.
And then you do another week and they're still grade 1. They haven't gone up, but they're now 52. Would you go in?
I would be...
I wouldn't.
I'd be tempted to give it a bit longer and maybe do an early scan and see if they're responding.
Yeah, I'm with you.
We know... Not only our clinical experience, we've published on what we call hyperacute toxicity, sort of bad tox after the first dose, but we also got trial data from after 2 dose Epi-Nevo. We're talking about 1 here, but even after 2 with a scan, often very early responses are seen. You can drop the Epi. It's the Epi that often drives a lot of that early tox.
So if I'm in doubt at all, I just hang 10. I won't give it, and I'll just do a scan, get them back. You've got time.
Yeah, I also think there's some really subtle, not even enough to be called a tox signal, but...
Give us some.
I think one that you see often when they're pushed is this... They describe this kind of relatively mild fatigue, but definitely real fatigue. Yeah. I think
it's not like the PD-1 afternoon 2 o'clock need a nap fatigue. It's more... It's obvious it's a change. It's after the first or second dose of Epi-Nevo.
And it's often worse with the first dose or second.
Sometimes a few fevers.
The itch, I think, is actually relatively okay. So often before the rash.
That one's associated with response.
Yeah, and on bloods, the subtle bloods ones are, they don't even get to the threshold of being called thyroid, but the TSH is suppressed, the T4 is normal, the eosinophil count that's gone from low normal to the top of normal.
Oh, yeah, that's a good
all
one.
these little things that I think if you look hard enough, even patients on trial where we don't do this clinically, but, the lipase just blips up, where you're not checking in the real world, but it's probably happening in lots of patients.
Yeah.
And I'm loath to call them tox. Certainly I describe them to patients as minor blood abnormalities that may sense that your immune system's being activated.
Yeah, I say that, exactly that. And I don't even call it minor. I'd say we've got evidence of immune activation. Yeah. I don't want to hammer you too much. Let's just hang 10 a bit and maybe do an early scan. Sometimes if I have a cluster of a lot of them, not just the fatigue, but a bit of fevers, a bit of fatigue, the CRP's gone up to 30, a few things, and there might be elderly or frail, I'll just hang 10. I really will.
The other one I think that happens quite often, particularly when we're giving single agent in our older people, are sort of polymyalgia-like symptoms, early arthritis, mild.
Mild achiness.
They try and play it down because they don't want to stop, and I'm still okay. And then you sort of look across and the wife's like, no, he's not great. Because they all are worried. I think they're the sort of cues that we get that not all is well.
Yes.
Often the nurses know before us because they've had the chat the day or two before and they can sense things aren't right. I think they're the cues we get. And of course, we're talking about people that, if you've got highly rampant aggressive disease and you're 40 and we've got to turn this around quickly, you're going to die. You may want to play it. You may want to.
Yeah, you may, but remember, if you're activating the T cells against the cancer, you're doing it. You're on your way. You can delay a week. You can delay 2 weeks. If we know we've all fallen into that trap in our, having used this so much, you're better off waiting a week and just checking those LFTs one more time. But I'm going to move to another topic on this. Yeah, I was going to ask you something, Inesh, but go for it. Yeah.
Yeah, probably. Oh, probably okay. No, because one thing that I'm loving, I completely agree. I think the discussion about toxicity is very important, and you touch on a lot of things. There's one thing that is important also is, so less is more sometimes, and I think this is one of the cases, because one thing that is, I have to explain to patients, I normally do is, if we push too hard, then we are probably doing more harm, because then we have a high toxicity, we have to give a lot of steroids, then we are doing the opposite that I keep explaining. So it does not make sense to stimulate your immune system to fight cancer, but then on the other hand, we are destroying your immune system with steroids.
That's a good point.
We are doing worse.
So if we overdo it, too much tox, we have to switch it all off, and that might not be good for your cancer.
Worse.
Yeah,
correct. And it's much worse. So I use that also to explain to patients.
Yeah, that's a good point.
And I was just going to say, on the back of what Inesh was saying, talking about steroids and how no one likes steroids.
I hate them.
I think we in melanoma and increasingly our oncology colleagues are really aware that we want to try and use if you get tox, to use as little steroids as possible. And it's how do we get access to more targeted therapies.
This is beautiful. This is exactly what I wanted to get onto next. I was going to ask Inesh, but let's go with you, Alex, and then go to Inesh on this. So this is about specific tox we see a lot, especially with the bad tox. So we're talking hepatitis, colitis, the neurotox, which can be very broad. They're the three awful tox. Any of the neurotox, the encephalitides, the ascending neuropathies, the radiculopathies, the transverse myelitis, like it can come in any form, the aseptic meningitis, I mean, I've just mentioned 5 or 6 that can come, plus diarrhea, which is the colitis, plus hepatitis. They're probably the worst. Would everyone agree?
And myocarditis.
And the myocarditis.
And pneumonitis, I think. Yeah.
Pneumonitis. Yeah. We're getting... So that one, just get them to walk up and down stairs, take their oxygen, dry cough. But what would you like to say about managing those horrible ones?
Yeah. So I think, early recognition is key and early intervention is key. I think what we are still dealing with in Australia and I think around the world is... because often you need other specialties to either do a procedure to diagnose it or to let you access therapy to treat it, it's getting people to understand that whilst these conditions mimic the idiopathic conditions they've learnt about through their whole career
so
and they see all
colitis,
day.
Crohn's disease, this ain't that.
So you might be an IBD specialist but when Ipi-Nevo colitis comes in the door, it is not ulcerative colitis, and it isn't something that's going to need lifelong immunosuppression, and you don't wait 6 months on steroids before you qualify for infliximab. These things need being treated early. So rheumatology, this isn't something that you wait 6 months for an appointment in clinic.
Methotrexate, this, that, just get on with the IL-6, knock it on the head, etc. Can you give us more on that colitis thing? Because I know with infliximab and vedolizumab.
Yeah, so look, we know that if you've got a barned or clear-cut walking in the door patient that's 2 weeks after their first dose of Ipi-Nevo, perfectly well, and has torrential watery diarrhea, that they don't have any other infective symptoms, they've not travelled, no one else is sick. It's clearly they've got urgency, nocturnal, diarrhea. It's Ipi-Nevo colitis. We get so frustrated waiting to, well, you've got to give them intravenous steroids, and then you've got to wait for them to go back to orals, and then fail on the orals, and then we'll scope them, and then
what would you like to do?
I'd like to give them infliximab in emergency.
Yeah,
and they'd go home the next day.
And when we've been able to do that, it's a very good outcome. When you get it early and you get infliximab, or sometimes if you get it really early and it's a bit milder, vedolizumab. And stop the Ipi-Nevo, for Pete's sake. Any patient who walks in with even 3 new loose, don't give more Ipi-Nevo. Yep. That is one time you have to hang 10. Probably never get another dose. Watch the diarrhea, send it for a calprotectin.
So I think I think the most important test, to be honest, is excluding infection.
Yeah.
That's full stop.
Yeah.
And the two parts of that are history and the stool culture. History is the thing.
When was the last time you had a patient that you were surprised had infective diarrhea?
No, look, I can remember
honestly
2 distinctly.
Yeah.
Out of
in my head,
less nowadays because we're more nuanced with the management.
And usually the history is great. The amount of them that get viral gastro off, they're typically grandchildren in my practice. The grandchild who they babysit on Thursday brought it back. But I think, look,
So that's a point, just to make that patient walks in, do a stool culture and a calprotectin, get the infliximab in their arm if you can, but try not to wait too long for them to fail steroids if you have to go down that path before trying infliximab.
If the steroids don't turn it off in 24 hours, you should be thinking about how.
And you wouldn't necessarily wait for the viral stools culture to come back before you start steroids if someone's got grade 3 diarrhea.
And a good story.
So I want to make that one last point before we go on to our next topic, and that is, and we learnt this as medical students and as physicians training, 90% of anything, the diagnosis is in the history. 90% of the diagnosis is in the history. So I just had a patient today, came in on the weekend with back pain low down, that then transferred to a headache, then cramping pain down the back higher up, then pins and needles and a few visual disturbances. As far as I'm concerned, that's a radiculopathy until proven otherwise. Needs to come in, have a CK, might be a triple M. She feels weak but not quite, and she needs an MRI, lumbar puncture and an MRI brain. Right, like the history tells you everything. She got a dose of steroids, 1 dose IV, and everything's fine and she's sitting up. Oh, we want to stop the steroids. No. We need to investigate this. The history is bad. Anyway, so just to re-emphasize everything we just said on that. So,
I guess,
one last thing. Go for it.
To summarise that all up, I think with good education and early recognition, even with our more toxic regimens, they can be very safely delivered, and the majority of our patients do not end up with life-changing permanent toxicity.
Correct.
And they're alive with cured cancer. So correct. I think this should not be the barrier for a treatment that can be curative.
And we don't give all the immunotherapy. We do not stick to that regimen. If you get 1 dose of Ipi-Nevo and they've got a great response, you don't need to go to maintenance Nevo either necessarily. So, all right, that was a great discussion. Thank you. Thank you for joining us for Redefining Immunotherapy Lessons from Melanoma, brought to you by Melanoma Institute Australia and made possible by an unrestricted educational grant from Bristol Myers Squibb. We acknowledge the Camaragal people as the traditional custodians of the land where we have been recording today and pay our respects. This discussion was accurate at the time of recording, April 2026, but may not reflect the rapidly evolving treatment landscape and approvals in Australia. For more practice-changing education, sign up to our melanoma education portal at melanomaeducation.org.au. Thank you for listening.